I'm down in the emergency department and I'm waiting for a code stroke to come in. I'm really busy, and quietly sidling up to me is this internal medicine registrar, and they go, look, we've got this patient, they've got dizziness/vertigo, they've been here for a day and a half, would you be able to come and see them? I've got about 3 minutes, and I reckon I could squeeze in a quick consult in that time. We get there, and I do one 30-second maneuver to figure out the diagnosis, nail the diagnosis there itself, and then I cure the patient in 2 minutes. What is this maneuver? It's the Dix-Hallpike maneuver. What I want to do is really explain what BPPV is. I want to explain the Dix-Hallpike maneuver, and then I also want to explain the Epley's maneuver. So this patient had BPPV, I used the Dix-Hallpike to diagnose it, and I used the Epley's maneuver to cure him. And then I went back to my code stroke. My name's Prashant, I'm a neurologist, I'm the founder of Basic Neurology, and I've taught over 4,000 doctors over the last decade, and I want to teach you about vertigo. So, whenever someone presents with vertigo, you need to figure out, is it continuous or is it episodic? If it's episodic, we need to know, is it spontaneous or triggered? Triggered specifically with head movements and rolling over in bed is highly suggestive of BPPV. And so we only do the Dix-Hallpike exam in episodic vertigo and specifically triggered episodic vertigo. We don't do it in someone with continuous vertigo. So let's just take a step back and think, what is BPPV? BPPV stands for benign paroxysmal positional vertigo. The vestibular system, we can think of it in two parts. One is the semicircular canals, and the other is the utricles and the saccules. There are 3 semicircular canals. There's the posterior, the anterior, and the horizontal canal. These are linked to something called the ampulla. And so we have endolymph fluid running within these semicircular canals, and we get the ampulla where we actually have the hair cells that are linked to the nerves that then go back through the vestibular cochlear nerve back to the brain. We have movement of our head leading to movement of this endolymph fluid within the semicircular canal that then triggers and fires these hair cells as it moves across the ampulla, stimulating the nerve and telling your brain that there is movement, that your head is moving, and so it can coordinate your eyes, it can coordinate your vestibular system and understand where you are. The utricles and the saccules are there for linear movement, and they're very important for linear movement. I'm not going to go into that in too much detail, but the important thing to note is that it's based on this system where there are these calcium carbonate crystals called otoconia, and they sit on this membrane. Now, don't worry about the rest of it, but these crystals are sitting on top of the membrane, and the utricles and the saccules are very closely positioned to the actual semicircular canals. So BPPV happens with one of these otoconia, calcium carbonate crystals, get dislodged from the actual membrane that they sit on, and they make their way into the semicircular canal. Most commonly, it's the posterior semicircular canal. Now, it drifts in and it drifts down into the canal. And by drifting down into the canal, you can imagine I'm dropping a stone into a pond, a clear, beautiful crystal pond. We're dropping a stone in. What are you going to see? You're going to see turbulence. The fluid is going to ripple. And in that process of rippling, that fluid is now traversing across the ampulla in a rippling manner. And the hair cells are getting triggered and fired because they think there is movement. And so we get vertigo. So patients will move their head in a specific position, and as they move their head, that otoconia will start moving, causing the turbulence, and then slowly the turbulence resolves. The hair cells don't get that signal, and it doesn't fire, and the vertigo disappears. So the classic syndrome of BPPV is they're lying in bed and they turn over, then over about 5 to 10 seconds, then they start developing their vertigo, and that's because we need time for the otoconia to fall down through the semicircular canal and cause that turbulence. Then we have a crescendo, decrescendo of vertigo. It gets worse and then dissipate, and then symptoms resolve, and it lasts about 30 seconds in total. So that's the classic history because it matches the pathophysiology of what's going on. When we are trying to figure out whether someone has BPPV, on examination, standard neurological examination, their exam should be completely normal. Nothing whatsoever. We don't find any neurology. But we have to reposition them in that position to get that otoconia going through the semicircular canal. So we do the Dix-Hallpike maneuver. So what we do is we position their head to one side, And by positioning their head, we're lining up the actual semicircular canal so it's on the right axis for this to work. We then drop them down off the bed, or their head off the bed, and we hold it and we give it some support. And by dropping their head down, we're letting gravity pull that otoconia down into that beautifully aligned semicircular canal, in the posterior semicircular canal, and we look at their eyes for nystagmus. Now, it's really important to understand that just if you see nystagmus, that doesn't make the diagnosis of BPPV. Absolutely not. By doing a Dix-Hallpike maneuver, you will accentuate any potential baseline nystagmus that's there. If they've got baseline nystagmus, then they're not technically got episodic vertigo. So you have to do this when they've got episodic, no baseline neurology. If there's baseline neurology, that's a red flag. And we are doing this maneuver to line things up. So we need to see a very particular pattern of nystagmus on their examination. And that correlates with the pathophysiology, and it correlates with the symptoms they feel. So we dip their head back. We should not see any nystagmus immediately. They should not have any symptoms immediately. So you dip their head back, you're doing the Dix-Hallpike, there should be nothing, and then 5 to 10 seconds later, as that otoconia is making its way down, the turbulence is building and it's making its way through the hair cells, then we see the nystagmus. What do we typically see? We see a mixed upbeat and torsional. We say geotropic, towards the ground. There should be a crescendo and then a decrescendo of the symptoms as the ripple in the pond starts agitating the water and then slowly starts dissipating. So that's what the typical nystagmus we should see. Now, it's a red flag if you dip the patient over on the Dix-Hallpike and boom, immediately they get nystagmus. And it doesn't fatigue, there's no crescendo, decrescendo, and we need to think, oh, okay, maybe this isn't BPPV. Typically it's downbeat, there's no torsional component. It can be horizontal as well. And sometimes it's bilateral as well. So if you're seeing all of those red flag signs, just take a step back and say, this doesn't look like BPPV. This might be something else that I'm dealing with. It could be something rarer like CPPV. This could be a central lesion. It could be something else. If you've got the patient in that position and you prove you've diagnosed BPPV, you now move to the Epley Manoeuvre. And what I tell my patients is it's like one of those old games you had as a kid. You got a little maze and you got a little metal ball and you have to move the maze to actually get it in. It's the same thing. We're going to try and move that little otoconia out of the semicircular canal and let it wash away. So we turn their head to the opposite direction. We let them sit there for 2 minutes. Then we turn them onto their shoulder with their head facing down for another 2 minutes. Then we sit them up with their head facing down again for another 2 minutes. And then we let them sit up. Now we want to do Epley's maneuver twice, and in between the two maneuvers, we want to see has the vertigo improved. And so if it's not improving after 2 maneuvers, it's again, think about it as could this be a bit of a red flag sign here? But overall, it's an incredibly effective maneuver. So that's BPPV, the Dix-Hallpike, and Epley. I'm going to leave a checklist on my website that actually walks you through what you should be expecting. So if you've got a patient, it's a very clear checklist that says, this is what you should look for on the history, this is the Epley's maneuver, this is what you should be seeing nystagmus-wise, and you can tick it off, and it's very easy for you to look at. So go to the website, I've got that checklist for you, completely free, and I'll see you soon.